Hello listeners, welcome to Views on Health. A great pleasure to have with me on the program tonight Dr. Bimantha Perera, consultant ENT, that is ear, nose and throat surgeon, teaching hospital from Anuradhapura. Well, a long drive from Anuradhapura to Colombo, Doctor. So welcome once again to our studios.
Thank you.
And Dr. Bimantha Perera is going to speak on obstructive sleep apnea. That's a technical term. To tell you all about it is our specialist here tonight on the program. May I hand the microphone over to you, Doctor, to explain obstructive sleep apnea.
Thank you, Fazi. It was a pleasure to come here and speak to you today. And obstructive sleep apnea. Okay, let's forget this term. Shall we just go to the lay term, snoring, which is actually the milder version of it. And I'm sure all of you would have heard what snoring is. And it's basically a noise that's created in your mouth and your pharynx, and involving a complex mechanism of muscles and skeleton and all that, having lots of deleterious effects, having psychological and physical disabilities.
So, Doctor, how does this happen? I mean, in the end of the day, I can't say, no one knows they are snoring, if I'm right, because one is asleep and one would snore. So, if you happen to have a spouse next to you, then he or she would hear. But otherwise, how does one know that one is snoring? So, basically, a person who's in a deep sleep, I would guess no, because I've heard it happen, I've seen it happen. So going by that, how would you explain the fact that it is happening, but the person doesn't know?
Quite ironically, this is not a problem of the patient, it's a problem of the spouse. Because obviously, he or she doesn't get to sleep when the partner starts snoring. Yes, basically, who has snoring? It's a good question. So we think it's adults, mainly obese people, but surprisingly there can be very thin, lean, young adults having it, and quite often children as well. I think that's a separate topic. Let's not deviate to the children's side today, but let's focus on the adults.
So adults will, as you said, even thin people can, but basically it's associated with obese people.
Yes.
So is it the position that they sleep in, because they sleep on whichever side, or is it because they sleep on their back, they are flat?
So it's a multitude of factors there actually. Let's just take from the basics. What do we have in our face, our mouth region? So we have a tongue, we have a palate, and we have a nose. And there's one area behind which is known as the pharynx, connecting all these areas. Now the problem is, when we snore, either we lie flat on our bed, quite often the palate falls back, and when you breathe, this palate can start vibrating. Now that's that noise, that horrific noise you hear. But complicating things, now that's basically snoring. But complicating things, if this completely obstructs, that's where the problems happen. Again, the tongue. If the tongue gets too enlarged, and that falls back as well, while you're in deep sleep especially, now that's even a bigger problem, because now there's no airway to, help you breathe, and that's where you get the obstructive sleep apnea. As you rightly said, it's not only these muscles and tongue and the structures of the pharynx that are involved. In obese people, fat around your neck and around the muscles, again, the fat getting deposited in the tongue causes all these problems. And again, their jaw movements are restricted when they're fat. So I think in our population, in the Sri Lankan population, we see this much more. Even if you just get slightly obese, you start snoring, unlike the Caucasians who need to be really, really big.
Doctor, it's interesting. Never heard that fat can get deposited in one's tongue. It happens.
So this was one of the latest researches they've done, I believe, in 2015, where they've shown that surprisingly, tongue is one of the first places where fat gets deposited. It was news to us as well, because none of us knew this before. And this was diagnosed with MRIs and published in Singapore, I believe.
So, because we always think of one's heart and
Yes.
deposits, around, your arteries get clogged and etc., etc. And so we have to be careful. Medication is given, but tongue. So when that happens, it can affect one's breathing.
Yes. So what happens is, just imagine, you're fast asleep and you're breathing. Now you need oxygen to survive. You can't live without oxygen even for a few minutes. So what happens is the tongue falls or the palate falls, either one of these, or both. Then what happens is the lungs are craving for oxygen. And what happens is, as a reflex, your heart rate goes up, your blood pressure goes up. And then that also sends a message to the brain that, oh, you're not getting oxygen, get up. So it jolts you and wakes you up. So this process happening on and on and on and on causes quite a lot of stress to you. It doesn't give you good sleep, though you really don't know it. In your subconscious level, you just don't get good sleep. And there's a stress to your heart, there's a stress to your circulatory system, there's a stress to your pancreas and liver. Oh, I think you've heard all these. First is high blood pressure, high tachycardia or high heart rate. The next, diabetes. Next, dyslipidemia or high cholesterol levels. Then we hear the end products, that's stroke and basically a heart attack. Don't you think that there is a relationship amongst all these? It's basically, we are treating the branches of a tree without cutting it from the root.
So how does one do that?
So that's where we come into play. And first, when someone comes to us telling that, you see, I have difficulty in sleeping because of snoring, I get up frequently. These are the frequent problems they come with. But some also come tell that, oh, they need to get up to go and go to the toilet quite often. And they are the most important complaint they all say is they have daytime somnolence. So they find it difficult to concentrate in the morning. They have heavy-headedness and they fall asleep very quickly. If they're sitting in front of the TV after lunch, they fall asleep. Some people come and tell that, oh, while they're having a meeting, they fall asleep. And this is quite a problem, especially in the high corporate sector. This is a major issue. So then what we do is we first evaluate them. We take a good history and we examine them. We check for their weight and height and calculate their BMI. And then we obviously, it sounds a little stupid, but we ask for their collar size. That gives us a good indicator of their neck, the girth around their neck and how fat they are. Then we obviously check for their BP, the vital signs, and then we do a sleep study. That's what's recommended. And the sleep study entails that they come into hospital, they stay one night, they'll be wired up from head to toe. Basically, they'll be checking their respiratory rate, their heart rate, how much they sleep with an EEG, and we can actually calculate how much of levels of sleep how long they stay in each level of sleep. There's something known as REM sleep and non-REM sleep, but I won't go into the technicalities. And that gives us a good idea how severe this patient is suffering. Now, of all this, the most important thing is we calculate how many times the patient stops breathing within 1 hour. It's not only stops breathing, we pauses breathing or stops breathing within 1 hour. And that is the clinical index we take to treat. And that will decide whether he has a mild obstructive sleep apnea, a moderate or severe.
Because doctor, when a person goes to sleep, straight away they don't snore. It just first they fall asleep, they get into a deep sleep, and then they snore.
Yes.
And you also said that they wake up. So, I mean, does the snoring that is taking place automatically wakes that person up?
Sort of. It changes from the levels of sleep, basically. So they may not completely get up, but that's how you and I would see. But he may be still either dreaming, or he may be, in light sleep. Let's tell it as a light sleep. So he goes to deep sleep, comes back to light sleep. So he really doesn't go down to that deep sleep quite often as he should. So he's not getting the adequate sleep he requires. So that's the end result. And that's what causes all the trouble.
Now, if a person is alone and there is no spouse around, then he or she will not know whether he or she is snoring. Or will they know?
That's a problem.
They will never know?
Lots of them come telling that they have this daytime somnolence. And
then you relate it back
to them. So, quite often I've had patients who come with a recording. Someone may have told that they snore when they go on a trip or on holiday, and then they record it on their phone and they show it to, "Sir, this is what happens." And I said, obviously this is obstructive sleep apnea or snoring. Let me just clarify again. So snoring may not have obstructive sleep apnea, it's just the noise. But obstructive sleep apnea is much more dangerous.
Are men more susceptible or women?
Statistically, men are more susceptible, and they're more susceptible to the dangers of obstructive sleep apnea as well.
Age-wise?
It can change, actually. Usually middle-aged, but different etiologies have different age groups. As I said, children, there's one subset. Mainly it's middle-aged men and women.
Doctor, you say that children also snore.
Yes.
So that the age factor can go haywire.
Go haywire, yes, that's what I said. And their treatment is totally different. And children usually snore. Majority of them snore due to tonsils. So if they have tonsils, we do a simple test, overnight sleep study, which is not as complicated as the adults, and see if they actually have this witnessed apneic attacks. Quite often the parents bring it on their phones and show, see, the child stop breathing. And then that's something we generally do a surgery and remove the tonsils and the adenoids as well.
And then they get over that?
Oh yes, they do get over that. But there is another part to it which applies to the adults as well. That's how do we manage this? Now, management wise, there are two aspects. One is obviously medical. The other one is personal management, basically weight management and your psychological well-being. Because don't forget, these patients have quite a lot of psychological distress, especially because they don't get good sleep. So weight management is key. I think I can't emphasize anything more than that. Because even if we are to do a surgery or anything, we say, please reduce your weight. That's the key.
Does this condition involve surgery?
Yes. So what happens is, once we evaluate with a sleep study,
that's the diagnosis.
That's the diagnosis. Then we give the patient the option. See, there is a problem with you, and we discuss in detail, because this is a long-term process they're going to deal with, and we give them the options. The first treatment option is a CPAP machine. The second treatment option is surgery. Now, if it is surgery that they choose, or if there's a more favorable patient, especially a young patient or a lean patient, then we would give them the option of taking them to the theater, giving them a little sedation, a little anesthetic, put them to sleep, and we will put a little camera down their nose and actually observe where this collapse occurs. Now, depending on the different levels of collapse, we can offer them surgery. But CPAP internationally, worldwide, is accepted as the gold standard of treatment. So, but that's a heavy, cumbersome machine you have to wear every night, and unfortunately compliance is not the best, but it's 100% cure. but compliance is only 40% in the best of countries.
Could you elaborate on that form of treatment?
Yes. So CPAP is basically a machine that which pumps air, which gives a continuous positive pressure airflow, which basically cushions your air in the pharynx and prevents any collapse. So it's simple as that. You just put a mask on and you sleep with the mask on.
So it's connected to the machine?
It's connected to the machine, and it keeps on giving a pulse, a wave of air, basically your basic air, but it's just given with a positive pressure, usually with rhythm. So it is not the most comfortable thing. I've tried it myself because before giving it to patients, so it's not the most comfortable thing. But once you get used to it, I'm sure it's quite good. The only thing is you have to wear it all the time, every night. And in this developed world, I mean, even airlines let you carry this on board. There are special machines, small CPAP machines. You can just take it in your hand luggage, because it would be disturbing to the other patients, passengers. And obviously you won't get a good night's sleep if you don't have that. So yes, CPAP is the gold standard. But now, as you know, in Sri Lanka, we cannot afford CPAP for everyone, and it is quite expensive. And we don't give that from the government as of now. So we tend to resort to surgery. And quite often in our Sri Lankan population, and even in the South Asian and Southeast Asian population, surgery actually tends to work better than the Caucasians. So that's because, surprisingly, when we put on weight, we put on weight around our necks and our mouth and tongue first. So we can always tell them, diet, and then let's see where your obstruction is. If it is something we can repair, we'll help you. But if not, CPAP is the best.
So in other words, that is also a factor that can be taken into consideration, the dietary factor. And then you diet, and then you bring your weight down.
And exercise.
And then, yes, all along, whatever you prescribe. And then when your weight comes down, your fat levels come down. And then your snoring can reduce.
But if it doesn't, we always have surgery. Now, there is a subset of patients, especially the thin, lean, young patients I told you about. They can have even nasal problems, like a deviated nasal septum, which actually is quite an annoyance rather than true obstructive sleep apnea. But that we can help. We can do a correction and help these patients.
Very interesting, doctor. So now, if you go back to a child, these devices may not work.
No.
How would you treat a child who's snoring?
Yes. It's a broad topic, but again, 99.9% of the children have obstructive sleep apnea due to tonsil enlargement and adenoid enlargement. If you diagnose them, if there is severe obstructive sleep apnea, we just go ahead with a surgery. If it's only the adenoids, we do treat them with some steroid nasal sprays. See for about 3 months. If it's not responding, we still offer them surgery. Now, especially when there are children, all children will have some sort of obstructive sleep apnea or snoring. Why? By the age of 6 to 7 years, our tonsils and adenoids are at its maximum size. So then you'll ask, why aren't we doing it for every child? No, every child will not have this severe witnessed apneic attack. And if they do have that apneic attack, that will be a problem. The reason being, children will not show daytime somnolence. They react totally differently. They react as hyperactiveness. And sometimes we may actually wrongly diagnose them as autistic. So that's very important that we diagnose these children early, and a simple surgery can, or even medication for that matter, can just help them.
Thank you, doctor. It's very interesting because this is something across the board. And also, there's no sort of gender.
No.
Sort of both genders are affected.
Yes.
So the gender is also like across the board. There's no relief for one or the other. And so the treatment is you have your options of this machine
Yes,
or the surgery, one of the two.
The last resort is doing a tracheostomy. That's making a hole in your windpipe to effectively help you breathe. I've been fortunate enough just to do it only in one person in my short career, but I've seen this patient who I can easily say in Sri Lanka weighed 180 kilos. 180 kilos, and she was not breathing. So we had to put down a tube, and the only way we could save her is actually do a tracheostomy, which actually saved her life. Then, once she came around, we explained to her and her family, who are all morbidly obese, told them the danger. They saw the danger to their own eyes, because I couldn't lift that mother at all. So I needed the 4 children to help me at that time. And they realized the danger. And would you believe, in 6 months, this lady really exercised and fasted and came down to a 99 kilos. And we just removed the tracheostomy. She didn't need any surgery or anything. And I've been told that she has even reduced even more now. So that's how effective it is.
That motivated.
That motivation. So I think we all need to get ourselves motivated for that. And it's basically our lifestyle and our diet that's causing this problem. And referring back to what you said earlier, asked earlier, sometimes if it's a partial collapse, yes, if the patient turns to the side and sleep, that might be just good enough, but it doesn't work for everyone. So we do tell them to see, when they turn to the side, is it effective? And we can see that in our sleep study. And then we just recommend the patient, turn to your side. Because surgery is not 100% cure. It will not cure you 100%. Why? You feel good after the surgery. 1 or 2 years you will have no problem. What happens again? You start eating. And then the fat would again come, and your surgical outcome may not be so great.
So that means you have to be disciplined.
You have to be
where your
disciplined.
diet is concerned, your lifestyle is concerned, and to keep your weight down. Then it can be a success story.
Yes.
But otherwise, like so many other, like somebody undergoes liposuction,
Yes.
is all slim and nice, and then 5 years again they put on weight.
So
Unless they are disciplined and they
unless
maintain
they're disciplined, yes.
that weight.
Actually, my teacher, she used to advise to the patients, and I do the same actually. She advises the patients just to eat just a handful of rice and fill the rest of the plate with vegetables and whatever the proteins you wish to have, and slowly reduce the amount of food you take in, because once your stomach is small, that's fine. That's all what matters. Now, there are some patients who are obese and who really we can't control all these things. We do refer to the bariatric surgeons as well to see if they can help with the reduction of the stomach size and so on. That's another extreme, but today we're just focusing on snoring here.
Interesting. So, just another question. Now, you do your treatment, and then of course, your surgery is not 100%.
No.
But the machine is.
Yes.
But you have to go through that process of having that mask on every night, no matter what.
Which many people don't.
Find it uncomfortable, I guess.
Find it uncomfortable. International data suggests it's only 40% of people who actually wear the mask. But surprisingly, in Sri Lanka, we have a much higher take-up. I suppose because the patients have to buy the machine with their own money, so they have much more value for money rather than getting a free product. So that's why I think our success story is much better here.
With the mask, do they can move to either side to sleep or and lie flat? How does that work?
They can, but there is a risk that it can come off. So it's not the most comfortable one because you need to tie around your whole head. There are smaller devices at the moment. Now, apart from the CPAPs and the surgery, dental surgeons also come into play because our jaws also matter. The size of our jaws also do matter. And for a subset of patients, just by putting a mandibular device and bringing your jaw forward, could solve the problem, because that would prevent the tongue from falling back. But that's not for everyone.
Well, Doctor, very interesting, and time has caught up with us. So what would be your take-home message?
The take-home message here is discipline ourselves, eat healthily, exercise well, and keep your weight down. And if you do have snoring, or if you do have any hint or doubt about it, please seek medical advice, and that would prevent a lot of trouble. Always, as I said, rather than chopping the tree from its branches, it's best to uproot it from its roots itself.
Just a rider, you did say that even those who are slim, not
Yes.
all, can snore.
Yes. So even they do need to get medical advice, because we can treat them. We can treat snoring, and it should not be a stigma.
But that's not a lifestyle issue, because their weight is under control.
No, but they may have some anatomical problem which we can correct.
So that's where they have to get medical advice.
Yes.
Thank you, Doctor. And on that note, we end this very interesting discussion on obstructive sleep apnea. And thank you, Dr. Bimantha Perera, consultant ENT surgeon, Teaching Hospital, Anuradhapura. Thank you so much for sparing a very valuable time and being with us on the program. We truly appreciate it.
It was a pleasure taking part today. Thank you.
My thanks also to Malintha Deshapriya for technical assistance. I'm Fatima Razikada saying good night and looking forward to your company next Monday same time on Views on Health.